Hey guys, it's Dr. Steph here again, and I'm going to be speaking to you guys about Family Medicine Billing Part 2. This is for the PGY2s. Since you guys will be graduating soon, we're going to be talking a bit more about some of the details of family medicine billing. So, if you have not had any billing lectures ever before, just make sure you get a refresher from the PGY1 YouTube lectures. So for the first year residents, we talked about some things like what are the most common billing resources you should use, what are the different types of EMR systems, and what are the high yield billing codes. So you should be sure to watch that. Link is in the description if you ever need a refresher on that kind of content. So what are we going to talk about today? So premiums and modifiers, what are those? How do we deal with rejected billings, WSIB as well as uninsured billing, and practice billing cases. And if you haven't figured out what my favorite medical word of all time in medical school was, it is high yield, because that part is really high yield. Just as a disclaimer, don't have any conflicts of interest to disclose. I'm not being paid to do this on my weekend. And OMA and CMA has made every effort to make sure that those practice billing questions at the end of this lecture are representative of best practice billing. So as usual, I usually like to kind of engage my audience and ask my students, what kind of setting you want to see yourself in. And for a lot of students, they want to practice in the community setting. And the reason I ask this is because, this is what I expect. A lot of students, when they graduate from family medicine residency, will start practicing in the community. And so a lot of the content in my lecture is geared towards those students doing family medicine. Now, I know that there's a couple of you guys who will be doing focused practice and ER, and your billing codes might be completely different because you would no longer be billing certain billing codes that someone in a family clinic would be billing. So just so you're aware, when you guys do your focused practice year or your ER year, there will be dedicated billing lectures in your fellowship programs. But if you stay behind in some of the practice questions, I do cover a few of those like ER billing codes or some focused practice billing codes as well. And then I also asked students, when you're accepting your job offer, do you kind of have a good sense of whether this job, the overhead or the pay is fair? And interestingly, a lot of people who are graduating actually, in their last 3 months of graduation, from graduation in R2, they're not really sure what they should be making or whether a contract is fair. Usually in these lectures, the negotiations and the contracts lecture is being given by another individual, so I won't really be touching on that today. But what I would suggest from what one of my students told me is that the OMA does offer contract reviews for free. So make sure that if you're unsure about your contract and you want someone to look at it, you can either ask a more senior physician or a mentor, or you can ask the OMA. Only downside is that the wait times can be kind of long. And so, the other thing I just wanted to say is if you're in this category, like if you're the type of person who is happy to take any job offer regardless of whether it's competitive or not, I don't think you need to be in this category, because in family medicine, we're fortunate to have access to lots of jobs available. So, don't try to sign on to the first thing you get. Make sure you do your due diligence as well, okay? You don't have to be desperate about trying to find a job. So let's start with talking about premiums, modifiers, and bonuses. So special visits premium, this section, the key things I want to draw your attention to is if you do a home visit for a patient, you can bill this billing code if it's, for example, in the evenings. And you also can add on a travel premium, which is, if you drive to that patient's house to do a home visit for them. So you can build these two billing codes together. And there's also office visit premiums, which is if you cancel your office and you're not going into the office that day, but you want to see your patient in office, right? So you show up in your office, your patient shows up, and you see them there. And I usually bill this a lot, so because I also do inpatient addictions, and I sometimes have to be called in because I have to respond to a call. So if I respond to a call, for example, on an evening, I would bill this code. As well, I would bill the travel premium. And this travel premium is kind of nice because if you have a car, you have car maintenance costs, you have gas costs, and this kind of helps cover that a little bit. So the other thing to not get confused about is special visits premium is different from special premiums. So if you're in a FIG, a CCM comprehensive care model, or a family health organization type of patient enrollment model, you get access to these special premiums. If you need a refresher on what these things are, like what all these acronyms are, you can always watch my YouTube lecture, How Do Doctors Get Paid? It's on my profile, so you can find that there as a refresher. But what this is basically it's like a bonus to incentivize doctors to provide comprehensive care. So this can be up to 37 grand for faux models and 28 grand for FIG models. And so what it might look like, and this is what, you know, the government's definition of comprehensive care is, if you provide all of these procedures as part of a faux, so you have access to all 8. If you add these all up, it becomes 37 grand. And in green are the ones that the FIG and the CCMs have access to. So if you do a lot of these kind of procedures, you do long-term care for a certain number of patients, you get access to that as well. And just as a heads up, usually there's no extra codes to bill for these, but let's say if you see mental illness patients, you have to kind of include an extra code called a Q code. So for example, if you have bipolar patients or schizophrenia patients, and if you have at least 5 to 9 of these patients in your roster that you're seeing for mental illness, every time you see them, don't forget to bill these Q codes because it gives you a bonus of an additional $1,000 a year. For these other ones, you don't need to bill these extra Q codes listed here. So modifiers and Q codes. So what these are is I kind of think of them as codes that kind of provide additional payment or / tracking codes. So for example, how would the government know, or how would the ministry know if you've seen a patient after hours, like after 5 p.m.? Well, they would know by adding a Q code, like a Q012, to your, let's say, A007 code for seeing a patient after hours. And then that kind of triggers that premium that you get. So for every billing code you bill after hours that you add a Q012 to, you get this extra premium of 30% on your code, on your original billing fee. And keep in mind that not all of these Q codes apply for doctors working in different payment models. So for example, the newborn code might only apply to doctors who work in a faux setting, for instance. And a lot of these codes can also provide some additional benefits that are paid, you know, outside of the schedule of benefits, right? So for example, if you have a patient coming in from Healthcare Connect, and which is like a doctor finding service for patients without doctors. Sometimes if the patient's really complex, they might have a Q053 reminder on that referral, which gives you an additional $350, for instance. So the other thing about Q codes is that on that previous slide, those actually aren't all the Q codes that exist. When you work in a faux, the billing, you might earn a little bit more, but the billing is a bit more complicated. And often in residency, I remember spending like 3 hours in a billing talk learning how to bill as a faux. But to be honest, I don't even work in a faux. Neither of my colleagues work in a faux. And when you look at the majority of family doctors, they do not work in a faux either. A lot of the times they work in a FIG or a fee-for-service, and FIG is a enhanced fee-for-service model. So what I would refer you to is this document, because it talks a bit more about some of the other Q codes that are talked about in the previous slides. And this is like a 29-30 page document. So this is basically like going through this is like an entire talk all on its own, like another 30-minute talk. So I don't know, if there's anyone out there who does work in a faux and you want to collaborate on like a faux billing lecture specifically on that topic, happy to do that with you as well. So preventative care bonuses are things that are also applicable to any doctor working in this type of payment model. And this is just something just to incentivize people for doing all of their preventative care stuff, flu shots, pap smears, fit testing, things like that. And when you add up the total, like of the max, like if you do all of these preventative care for up to 80% of your entire roster, you add these all up and that sums up to $12,800 a year. So when you do see a patient for something, for example, like a PAP, and you're in that certain, and they're an enrolled patient of yours, you can add on a 𝗧𝗃𝗰𝗀 pap smear Q code as a tracking code, and it basically tracks how many of your patients have gotten a pap smear. But let's say you have a patient who, you've talked to them about the pap smear, but they're like, oh, I don't want to get a pap smear, and you don't want it to like dock your percent roster getting that particular preventative care. You can put in an exclusion code. So that kind of excludes that patient, and it suggests to the Ministry of Health that, look, you've talked to the patient about it, you've done your due diligence, but the patient declined to get a PAP. So these are just some heads up about this kind of stuff. Just as a FYI, this is a typo. It's actually not Q012, it should be Q102. And this document is from 2015. I haven't been able to find anything newer than that, and it's the best thing we got. So just wanted to let you guys know in case it creates a bit of confusion for our students. So what about dealing with rejected billing codes? Because, you can bill something, but then it gets rejected and you don't even know why it's rejected. And I would say that rejections are also super complex. I don't know why things are so complicated, but we have billing codes, you have all these acronyms you have to know in family medicine, and when you get a rejection, you don't actually know why it's rejected, you just get a code that tells you why it's rejected. So what you have to do is, if your EMR system just provides you with a code that tells you why your billing is rejected, you have to go on this website, which I linked down below, go on to section 6, and it'll translate the codes for you as to what this code refers to, like what's the reason for rejection. And the most common reasons for rejection are these common reasons. I've kind of written them down for myself. And a lot of the times it's when your like health card version code is expired, or their health card is expired, or if, for example, a patient saw another telemedicine doctor, and you're also working in a telemedicine clinic, for example, and they put in a request to see a doctor at 2 of the same telemedicine clinics. That other doctor sees that patient first before you. So by the time you get to that patient, that doctor has already billed their billing code, so you can't bill that same billing code again. And so that's why it gets rejected. So these are just some of the common reasons why you might get rejected. Probably the version code is my most common reason. And so what happens if you get a rejection because a patient has an expired health card number or an expired version code? And this has been happening a lot during the pandemic. So nobody has told me this, so it took me kind of a long time to try to figure this out, so I'm telling you this now. Basically, there's a health number release service. I've put the number right here. And in order to use this service, you can't just call the number directly. You have to get a PIN. So in order to get a PIN, you have to email this email, get yourself a PIN, then call that number and tell them your PIN and tell them the patient's like name and whatnot, so that you can find out what their version number or what their health card number is. And this is really time consuming, so it's something that you can always delegate to your billing or office manager, so that way they can help obtain patients' updated health info. And this is really useful when, let's say you're working in a walk-in and you never see that patient again, so you can't actually like call them back and ask them what their health card number is. You can use this service instead. So what about uninsured services billing? So this is a pretty large topic on its own, and often we might encounter services that patient asks for that aren't actually covered by our provincial OHIP or WSIB. So instead of telling you to memorize a lot of things, I want you guys to know where to look for it. So I've linked the resource down below. This is kind of like the guide to anything uninsured service, and it's published by the OMA. And things that might be uninsured might be like attending physician statements, insurance forms, lawyer statements, anything that's like billed directly to the patient, for instance. So it also includes what kind of fees they recommend you to charge for that. And as residents, we're really used to doing things for free. And but something to remember is your income, it actually pays for the income of your staff as a sole proprietor. So it pays for the income of your nurses, of your secretaries, and it also pays for things like office overhead, like rent and maintenance of stuff. And often in residency, it's not really a good representation of the majority of you guys who will be practicing in a community setting, because in academic family health teams, there's usually funding to cover for a lot of like these kind of things, instead of having our overheads cover that. So you also have to remember, whenever we do something for free or we get something for free, we might not value it as much, right? So you just have to remember to recognize that your time is valuable. Just because a patient may not be paying for your time, that time is still valuable as well. And also just remember to stand up for yourself as well if you're not comfortable doing something, because we often feel, you might hear news reports about doctors getting verbally or physically assaulted in the media. And so it's just important to stand up for yourself, establish boundaries of what you will and what will not do. If a patient is constantly coming in for sick notes, stand up to their employer and say this has a charge, the employer needs to pay for it if that's kind of a rule at their place of employment. So just stand up for yourself as well. And the other thing is, when it comes to charging people for stuff, take this in the context of the social economic status of your patient. Usually in lots of low SES patients, they might not be able to afford something if they're asking for a sick note. So you don't want to try to charge them for every little thing. And often if you do see a lot of low SES patients, the payment model tends to kind of help accommodate for that. So you'll often be paid in a salary model. So what should we charge for uninsured services, and what do uninsured services look like? So often I see clinics will post this up near their front desk as a reference. And the most common thing I find people charge charge patients for is actually the sick note, which based on the OMA guidelines, it's about $21. And whenever you're doing things for like a lawyer, for example, on an hourly rate, they recommend, using this multiplier for uninsured services and using an hourly rate calculator. So this is what the hourly rate calculator looks like. If you have an OMA membership, which most of you guys will, this is how you can kind of determine how much to charge for uninsured services based on an hourly rate calculator. So what about WSIB? So WSIB is basically your Workplace Safety and Insurance Board. And this is for whenever a patient comes in because they got injured on the job. So in order to bill for WSIB, you need to get a WSIB provider ID. And how to do that is you need to go on this website, which I linked down below, and click register for WSIB, and you need to get this provider ID here. And so when a patient comes in to you for any sort of workplace injury, you want to encourage them to work with you to fill out a Form 8. And so a Form 8, if you complete it on the WSIB, like on the website there, it's $85 when it's online and $65 if it's in paper and faxed. And when a patient is ready to return to work, you would fill in something called an FAF form. And so this kind of allows the employer to know what their function is like, what kind of jobs they can do, whether they need to do modified duties or not. And that kind of provides some information for the employer. And a patient will usually come in with this form, and this pays about $40 when you fill it out. And so the WSIB has their entirely own fee schedule as well, and their own guideline. And so I have linked it here for your reference. And there's a lot of different forms that you can fill out for WSIB, which I've kind of screenshotted here and how much they pay. And just some key points that a lot of people have recurrent questions about when it comes to WSIB is, remember, the WSIB pays the patient for time off due to injury at work. And a lot of companies will subscribe into WSIB so that if an employee gets injured at work, it's not necessarily the company that has to pay for their time off and for their physio and whatnot. It's WSIB that pays for that stuff. And so you always want to ask your patient if they come in for a workplace injury, if they have coverage by WSIB. And some patients are hesitant about, submitting a WSIB claim because they're worried that their employer will fire them for taking disability leave or getting disability pay. But it's important that you kind of encourage them to do that, because workplaces subscribe into it for that reason, so that they don't have to pay for the disability leave. It's WSIB that pays. And remember, you can't bill OHIP and WSIB for the same assessment. So if you have a patient who comes in for like a knee injury, for example, that occurred at work, you shouldn't be billing OHIP for that and be billing that $85 for it at the same time. And just remember, if your patient refuses to, go to WSIB, or if they refuse WSIB altogether, they refuse you completing that form, if you're assessing them for a knee injury and you're managing them for that, you can't bill OHIP for that because it's a workplace injury, and you also can't bill WSIB for that if you if they don't let you submit to WSIB. So in that case, you would charge them the uninsured rates, the OMA recommended uninsured patient rates. So let's do some practice cases, and there's about 20 or so practice cases in this section. And if you're not sure about the answer, just ask in the comments. So a lot of these practice cases were created, I think, by the OMA. And so we'll try to go through them. Some of them might be more specific to, ER residents. They might be more specific to some +1 residents as well. So there's going to be some of those questions scattered in there as well. So what I would recommend is pause the video and write down on a piece of paper what you think the answer will be, and then I'll tell you the answer right after. So scenario 1, you cancel your clinic that day to do a house call for an elderly patient with severe arthritis and dementia. Which of the following codes would you be billing? So write this down, pause the video, and the answer is C. So why is it C? So let's go to the screenshots of the SGFP document. And what I would recommend how you do these questions is have that SGFP document with you so you can control find. Because realistically in clinic, how I usually bill is I will have my billing software open, I'll have the SGFP document open, and I'll just control find. No need to memorize anything. So here's the thing, since this document is from 2015, for a lot of students, they will write this as the answer, anything with like an A901 in it. But the reason why it's not an A901 is because it's now obsolete. And these are just things that you don't actually know until you've billed it by accident, and then you find out it gets rejected, and then you search around for why the reason is, and you find out that some billing codes have been obsolete in this 2015 document. So the answer is A900. And I've put this screenshot here just to jog your visual memory for the sacrificing office hours that day, because you canceled your clinic, B992, as well as your travel premium of B961. Okay, scenario 2. You canceled clinic to respond to an urgent house call between 3 to 4 on a Wednesday, and the patient has palliative breast cancer. So pause the video, write down your answer, and the answer is A. And the reason why is if you go under the palliative care section, K023 is when you provide a support for your palliative breast cancer patient. And you also want to add on a B998 and a B966 for the special visit premium. Okay, scenario 3. So you do a complete physical for a 50-year-old patient where you counsel them on their cholesterol, and you also provide them with a FIT test. So write your answer, and the answer is B. And a lot of people will say like, oh, why is it not the periodic health visit? Why is it not K131? Okay, so it's not wrong. It's still the right answer. But I think what this question is trying to get at is sometimes there can be 2 right billing codes you can bill, a K013 or a K131. But if you notice here, the K013 pays more than a K131. So if you haven't used up your 3 units a year of this counseling code and you counseled him on cholesterol, then you would want to try to bill the one that pays you more rather than the one that pays you less. So that's kind of the reasoning behind that as well. Okay, so in this question, you work in a FIG and you cover Saturday walk-in clinic. You see a patient with a cough and cold. What would you bill? Write your answer. And the answer for this question is either A or B. And this is the reason why. So your Q012 code is for your premium. So like your evening, like you're working on an evening or a weekend, you get a premium extra 30% for that. The 𝗧𝗃𝗰𝗀, some people have asked about that. It applies to CCM models, so we don't really bill it that often. And a lot of times students will respond either A or B, and either are correct, both of them are correct, but I would say that 𝗂𝗃𝗃𝗃 might be a little better, just because if you're working in a walk-in setting, and if you have a patient who comes in and they're already rostered at a FO, but they don't see their regular family doctor, they see you in your walk-in clinic. So 𝗂𝗃𝗃𝗃 doesn't negate a FO's access bonus, whereas 𝗂007 might do that. So just remember, you don't want to negate a colleague's rostered patient's access bonus by seeing them, so you can build an 𝗂𝗃𝗃𝗃. The other thing is if you work in a FO and you're seeing someone as part of your walk-in clinic and they're rostered to you, you want to build an 𝗂𝗃𝗃𝗃 because it is out of basket. So notice it has the N and the O next to it. That's a memory trigger for that being the out of basket codes. Okay, scenario 5. You are taking on a new patient from Healthcare Connect with a complex medical history. What would you bill for this? So take some time to control find on the SGFP document and write down your answer. And the answer is B, the Healthcare Connect complex vulnerable new patient. Okay, scenario 6. A patient comes in for a steroid joint injection in both knees. What would you bill? Do your control find on your SGFP document, write down the answer. And the answer is C. And here's the reason why. So for there are two knees, right? So I notice a lot of people will put A as their answer, but the reason it's not A is because for the first knee, you would bill this billing code. Then for the second knee, you would bill this billing code. And remember what I mentioned in the first lecture about these symbols, that you should pay attention to them. It's like a memory trigger to add in one of these tray fees as well. So make sure you pay attention to all of these symbols because there are all of these visual triggers for you. All right, scenario 7, WSIB. So you evaluate a 33-year-old typist with history and signs of lateral epicondylitis. They also ask you about a rash. You prescribe a steroid cream and physiotherapy. What would you bill? So the answer to this is A. And the reason why is because your 𝗂007 is billing for the rash and the steroid cream. So that goes to OHIP. You can't bill like the rash to WSIB unless it occurred as a result of work. But the lateral epicondylitis was a result of work. So you would fill out a Form 8 to WSIB so that they can have time off to help with their lateral epicondylitis. Okay, another WSIB case. So let's say you have a follow-up visit with the previous patient in 4 weeks, and this shows no improvement. The patient has a WSIB progress form to fill out. What would you bill? So the answer to this is actually B. A lot of people get this wrong because I actually didn't talk about it in my lecture, but I wanted to give this as an example because notice how the patient shows no improvement. If they were showing improvement, then maybe an FAF form would be relevant. But here is the screenshot from the WSIB billing schedule of benefits, and it shows you kind of what that form is. It's just the progress report, and it pays about $60. Okay, ER billing. So you have a 55-year-old with chest pain, and they present in the ER in the evening on a weekday. What would you bill? So the answer for this is A. And what I would actually recommend as a really good resource for if you're working in the ER is not actually that SGFP document. It's actually this document, the EM London document, because I like how they organize everything. I think just the organization is better. So it's an H132 because it's on a weekday evening. And a lot of people will ask me, what's the difference between comprehensive and multi-system assessment? Like, what's the difference between A and B? And I've asked this to a lot of my eMERGE colleagues. So if you're an eMERGE and you have an opinion about this, please write it in the comments because I'm actually really curious. But from what my eMERGE colleagues told me is that when they do a comprehensive assessment, it it's like what a med student would do in the emerge. So it would include a social history, a family history. So it's very like detailed. Whereas a multi-system assessment might not necessarily do that, but they might check up on several systems at the same time. So I guess either of these could have worked, depending on how detailed your note and your history taking was. Okay, ER billing number 2. Oh, the answer accidentally showed. But if you're an ER doc seeing a patient for multiple systems assessment and you admit to the hospital as covering overnight, what would you bill? So remember, the hospital list admission is at H105, so that's why it's all included in the answer here. And for the H133, that's actually referring to a multiple system assessment. So you might have checked more than one body system. Okay, scenario number 11, ER billing again. You see a patient in the ER for a shoulder dislocation at 1 a.m. What would you bill? So the answer is B. And the reason why is because you're doing a multi-system. So for example, you not just check the shoulder, you check other systems as well, right? You might check their wrist. You might potentially check their head if they've hit their head as well. And the dislocation code is D016, which is glenohumeral with anesthesia. And because it's after midnight, you would bill this premium E413. Okay, so scenario 12, OB examples. Let's say you do a delivery at 1 a.m. having augmented the patient. You do a postnatal visit to the hospital. What would you bill? So write down your answer, and the answer is C. And the reason is if you look at your obstetrics section, the P006 is for any time you do a vaginal delivery. If this was your sole delivery, you get a premium on that. And so that's where the 411 comes from for doing that first delivery. And the 410, it comes from the nights because you do this at 1 a.m., so it's after midnight. So you get this as a premium. And then you augmented the patient, so you bill a P023, which is the oxytocin stimulation. And you also do a postnatal visit at the hospital, which is the P007. So in total, it would be this amount, which is quite a lot, but also a very tiring job to be doing. So I guess you get paid accordingly. Another OB example. So you did a delivery at 7 a.m. and now you attend a labor and assist at a C-section, which took 1 hour, and that started at 9 p.m. What would you bill? So this is the answer. So it's D, P009 plus E409. And the reason why is a P009 is for when you attended labor and delivery C-section, and you also did a delivery at 7 a.m. So you had a premium for the days. And this bills about $249. So the sum of this is $748. Okay, so OB example number 2. Sorry, the answer kind of just popped up, but let's say you do a prenatal during the after hours in a faux. The example that the thing I want to emphasize here is in a faux, a P004 is, as you can see by these symbols here, are out of basket, so you get the full billing code. So you want to bill either of these ones that are out of basket instead of these ones which is in basket. So these pay a little bit more. Scenario number 5. So for some reason the transition didn't show up, but let's say you do a prenatal during after hours in a FIG. So this is what I was talking about earlier, right? So let's say if you work in a FIG, the A007 would actually pay more. Reason being is that they have a 10% premium added to it, to these billing codes, but not the P codes. And if you do it after hours, you get an even higher premium to the A codes, but not these P codes. So that's why in a FIG, it would be a little different what you would bill. Okay, scenario number 16, diabetes. Let's say you see a diabetic patient for their 3-month diabetic care visit. What would you bill? The answer would be a K030 And this is the reason why, to jog your memory. And just as a memory trigger as well, because we talked about this in the first part of the lecture, if you see them more than 4 times a year, and you're in an enrollment model, like one of these models, you get to unlock this particular billing code. All right, smoking cessation. So let's say you see a patient for cough and you find that they smoke 1 pack per day. You counsel them on the nicotine patch. So for this particular example, the answer is C. And the reason why is you want to build 𝗂𝗧𝗄𝗧 for cough, but then you also counsel them on smoking. So that's when you add the 𝗂079 to it as well. The other thing I wanted to mention about the previous slide is for K039s, just remember you can't combine it with an 𝗂007. It has to be a dedicated smoking cessation counseling visit. So we talked a little bit about that in the first lecture. Okay, procedure questions. Scenario 18. This is an office visit and the patient is concerned about a changing mole on their back, and you decide to do an excisional biopsy at the same visit. Which of the following would you bill? So write down your answer, and the answer is D, none of the above. The reason why is because you want to find out what the biopsy showed. If it's malignant, you bill a different set of billing codes, which includes the R094, and that pays a little bit more. And you also bill this tray fee right here. So remember, you get paid $91 versus $62, and so that's why you want to wait until the pathology report comes back. And a lot of these codes right here, the Z codes, they just refer to whether you have a biopsy with sutures or not. In this case, it doesn't. I guess they just, whoever wrote it, decided that it wasn't that they don't have sutures. So that's why that was the answer. Okay, number 19, procedures. So let's say you're on a telemedicine call with the patient and they told you that there's a mole that is changing color. You're not sure if it's malignant, so you decided to e-consult the nearest dermatologist 3 hours away. You take a picture and you submit it for assessment through the provincial e-consult service, and then you get an opinion back in 4 hours. So take some time to control find your answer. And the answer is A. And the reason why is because you bill the K081 for that visit where you're talking to your patient, but you can bill another K7338 if you go on OTN and you e-consult a dermatologist. So you're the referring physician, and that pays about $16. Scenario 20, procedures. So a patient presents with a plantar wart and you apply liquid nitrogen. What would you bill? So control find, write down the answer, and the answer is A. And so the reason why is because you probably talk with the patient really briefly about the plantar wart, and then you bill a Z117 for the time when you put liquid nitrogen on it. You can also bill the Z117 if you're applying the 𝗏𝗏𝗀 as well. And scenario 21. So a patient with tennis elbow is unresponsive to NSAIDs and physio, is seen for follow-up, and you decide to inject with a cortisone. What would you bill? So the answer is B, and this is the reason why. So whenever you do a 𝗧𝗀 injection, you only inject one 𝗧𝗀, right? So it's G370. And you probably talk to them really briefly, so it's an A001. And this part here says who pays for the cortisone. So remember, you can either bill the patient separately, $10 to $15 to pay for that cortisone vial, or you can give them a prescription for the cortisone, and they can refill your supply with their prescription, for example. So just remember the golden rules of billing. Be honest, document, 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 and always ask if you're not sure. So if you have any questions, feel free to ask in the comments. If there's anything that you're not sure about some of the questions and answers we did today, write it in the comments, and either myself or somebody else who's watching who might be familiar with the billing code can write it in as well. And feel free to reach out to me if you're an instructor or a student at Breaking Bad Dead on